Tonight's featured presentation is entitled Adapting Your Practice, Recommendations for the Treatment of Chronic Pain in Underserved Populations, and it is CE approved. Our distinguished presenter is Dr. Barbara Wismer, who's an MD and MPH. She's worked with the underserved populations for her entire career and with homeless people for 14 years, both as a clinician and as an administrator. She is a physician at Tom Waddell Health Center and homeless programs in San Francisco's Department of Public Health. Prior to this, Dr. Wismer did community-based preventive research at UC Berkeley Center for Family and Community Health. She is board certified in both internal and preventive medicine. Her areas of interest include chronic pain, traumatic brain injury, cognitive impairment, and quality improvement. As I mentioned, this presentation is CE approved, and the CME credit has been filed with the American Academy of Family Physicians. Today's presentation will be divided into 3 sections with a brief intermission for questions from the audience at the end of each section. In addition, we will also entertain questions at the very end. Please feel free to send your questions and or comments throughout the presentation, and Dr. Wismer will get to them when we break for questions. So with all of that said, let's welcome Dr. Wismer.
Hello everyone, and thank you for joining us. Thanks for completing the poll. It looks as if there are folks with a range of experiences and comforts with managing chronic pain, and hopefully we can all learn a little bit tonight about how to better manage our patients with severe chronic pain. You can see, here's the title page. As Sabrina said, I'm an internist in San Francisco's Department of Public Health, and I've actually been there for 14 years. 11 of those I was medical director, and during my years there I've actually treated many patients with chronic pain, and I participate in the development of policies and programs to help improve our care of patients with chronic pain. I'm also on the steering committee of the Healthcare for the Homeless Clinicians Network, which is a national organization that sets the clinical agenda for the National Healthcare for the Homeless Council. The council is mostly funded through HRSA, and it provides training and technical assistance for federally funded healthcare for the homeless programs, as well as other healthcare organizations that serve homeless people. And they do work in the areas of policy and research as well. Here's a disclosure statement. In compliance with the American Academy of Family Physician guidelines, I hereby declare that I do not have financial or other relationships with the manufacturers of any commercial services discussed in this educational activity. These are our objectives: to understand the reasons why management of chronic pain is more challenging in homeless and other underserved populations, to describe adaptations to management of chronic pain, and to learn programmatic strategies and tools to improve the management of chronic pain. Why is this topic so important? Well, it's in the national news. There's a rising tide of opioid overdose deaths, and this is occurring against an historical backdrop of undertreatment of pain. It's a priority with the Healthcare for the Homeless Clinicians Network. We did a national survey last year that showed that clinicians lacked the resources for optimal pain management, lacked access to nonpharmacological pain interventions, and were uncomfortable prescribing opioids. You can see the council's website for results. I'll give you the URL at the end of the presentation. In response to this survey, we had a Healthcare for the Homeless Clinician Task Force develop adapting your practice recommendations for homeless adults with chronic pain. Why is excellent pain management so hard? Well, this drawing perhaps reflects the variety and complexity of our feelings about this topic, as well as perhaps some of the answers to this question. It's hard because pain is subjective. Opioids are abusable, and those are used often in the treatment of severe chronic pain, and past and current substance abuse impacts this. Providers tend to be undertrained and busy. Our society uses a moral framework for pain and substance abuse, and this affects providers as they provide care to people with chronic pain. Opioid prescribing is heavily regulated. And finally, providers manage pain differently. Why is it harder in underserved communities? Well, underserved communities tend to have more pain and suffering in their lives. Our tools for measuring pain may not be relevant or accurate in those communities. We tend to have fewer non-pharmacologic resources and fewer specialty resources. There generally are inadequate mental health and substance abuse services. Folks in these communities tend to have increased risk for abuse, diversion, and overdose. And in general, people's lives are more chaotic, which makes it harder to develop and maintain a treatment plan. Why is it harder in homeless populations? Well, homelessness increases the risk of chronic pain. It exacerbates suffering, makes pain management more complicated, and these are some examples. Homeless people tend to have more frequent injuries and assaults. They tend to have less optimal and timely treatment for problems. They're more exposed to the elements. They have more frequent behavioral health problems. They have more difficulty keeping appointments for myriad reasons, and they often lack a safe place to store medications. Now I'm going to review the basic topics and recommendations from the Healthcare for the Homeless Clinicians Network recommendations, called Adapting Your Practice, Recommendations for the Care of Homeless Adults with Chronic Non-Malignant Pain. Again, you can see the Council's website for the full report. These recommendations were written by a group of 18 homeless healthcare clinicians from across the country, including medical, psychiatric, and addiction medicine providers, nurses, pharmacists, acupuncturists, and researchers. Most of these recommendations are relevant and applicable for those serving other vulnerable populations. The first part of the recommendations focus on practice adaptations, and the second part of the recommendations focus more on programmatic recommendations. The first recommendation in the practice adaptations is focus primarily on fostering a therapeutic alliance at the initial encounter, recognizing that this may be the only opportunity to engage a patient in ongoing care. And I'll say more about this in a minute. The second recommendation is ask about physical and mental health, including a history of traumatic brain injury and substance use, history of chronic pain, and living situation, including residential stability. All of these impact diagnosis and treatment. Mental illness and substance use are more common in homeless populations and many other vulnerable populations and impact treatment options. A related recommendation is to assess every chronic pain patient for substance use and mental health issues. You can weigh the benefits and costs of using standardized screening tools by considering the prevalence of behavioral health issues in the patient population you're serving, as well as provider and staff resources and experience. In the history, it's important to develop a therapeutic alliance. Allow patients to tell their story and feel heard non-judgmentally. Build confidence that you have their best interest in mind, and help them understand that pain management involves comprehensive health care. Many homeless and other vulnerable people have had negative experiences with the healthcare system, and this is probably more so for people with chronic pain. It's important to be clear in the history. Clarify what your setting can offer. For example, you may work at a place where this is going to be a one-time urgent care visit, or you may work in a place where it's a comprehensive continuity primary care clinic with access to specialists. You can offer very different things for treatment of chronic pain in those two settings. Specify what the pace of your evaluation is going to be. Usually it takes several visits to go through a history of physical and develop a treatment plan for someone with chronic pain, and it's important to say that at the outset. Clarify whether or not and when opiates can be prescribed. Usually this is after the evaluation is complete, and usually that takes several visits, and it's important to be upfront and clear about that. Tailor the substance abuse history and explain its relevance. For example, you might say, information about your drug and alcohol use can really help me figure out what is the safest and most effective treatment for you. To tailor it, you can ask more general questions if no substance use history has been revealed, and re-ask those over subsequent visits. As patients get more comfortable, they may reveal more to you. Or you can ask more specific questions if substance use has been revealed. It's important to attend to the patient's mood and your own emotional reactions. Respond to frustrated or hostile patients with acknowledgement and interest. For example, you can say, "I hear how frustrating it's been to have this pain and try to find relief. Tell me more about how it began." On to physical exam. Defer the physical exam to the second visit if needed, or keep the initial exam focused on the area of concern. Perform serial focused exams as tolerated if they're needed. Look for evidence of occult alcoholism or addiction. The history may take time, and so you may need the whole first visit or even longer than that to actually do an entire history. And substance use may not be revealed in the history, as we were talking about earlier, so it's important to look for signs on the physical exam for substance abuse. The physical exam is an opportunity to continue to develop trust and rapport. It's important to practice what's called trauma-informed care during the physical examination and in all patient encounters, recognizing that individuals may have experienced some form of previous trauma. To say a little bit more about trauma-informed care, it's a strengths-based framework, and it's grounded in an understanding of and responsiveness to both the impact of trauma that emphasizes physical, psychological, and emotional safety for both providers and survivors, and it creates opportunities for survivors to rebuild a sense of control and empowerment. There's more information on trauma-informed care on the Council website. These are some of the basic tenets of trauma-informed care, which are just some examples of them. Explain what a comprehensive visit will entail. Let people know each part of the physical exam you plan on doing. And ask permission to perform the exam each time. Explain what you're going to do before touching the patient. On to assessment. The use of standard measures can help track progress as well as effectiveness of treatment. Some measurements of pain include a numeric rating scale, the FACES pain scale, and the centrality of pain scale. Measures of function include the brief pain inventory, the PEG scale, and PEG stands for pain, enjoyment in life, and general activity scale, and the 2-item graded chronic pain scale. I'll show you a few of these. So this first scale here is the numeric pain scale, and many people use this, and some or most of you may have seen this, where you actually rate pain from 0, which is no pain, to 10 being the worst possible pain. And again, you can use this for an initial assessment and then use it to monitor progress and response to a treatment plan. The FACES pain scale uses faces connected to numbers to do the same thing, and this may be better to use in patients with cognitive impairment or language barriers. This is the 2-item graded chronic pain scale, which includes measures of both pain and function. Let me get the pointer back here. And so the first question is related to pain, and similar to the pain scales that we looked at in the last slide, that it's asked, in the last month, on average, how would you rate your pain? Use a scale from 0 to 10, where 0 is no pain, and 10 is pain as bad as it could be. And then patients circle one of these, one of the numbers on this scale. And then for function, there's this question. In the last month, how much has pain interfered with your daily activities? Use a scale from 0 to 10, where 0 is no interference and 10 is unable to carry on any activities. And again, patients circle a number along this scale. And then to interpret, you add up the scores for each scale, and the average or usual pain intensity, if it's 1 to 4, that's considered mild pain. If it's 5 to 6, that's considered moderate pain, and if it's 7 to 10, it's considered severe. It's very similar for function, pain-related interferences with activities, and 1 to 3 is mild, considered mild, 4 to 6 is moderate, and 7 to 10 is severe impact on function. Again, these can be used for initial assessment and then to track progress toward treatment goals. The centrality of pain scale is a newer scale that assesses the extent to which chronic pain is central to a patient's life. It can be used to develop goals for chronic pain management and to track progress toward achieving them. The scores range from 10 to 50. And the instructions to patients are seen at the top. Please rate how strongly you agree or disagree with each of these statements about them. Think about how your pain has affected your life over the last month. And patients can say whether they strongly disagree, neither agree or disagree, agree or strongly agree. And the different, just to read a couple of these, the first is who I am. And through this, you can get a score that reflects how central pain is to a patient's life. Urine drug testing. This can be as well as non-prescribed opioids to help minimize diversion or misuse or abuse by patients on opioids. So for the subset of patients with pain who are on opioids, this may be helpful. You can also use pill counts and prescription monitoring program data to help monitor treatment adherence. Just to make sure some of the terms used in this slide, diversion is the intentional transfer of a controlled substance from legitimate distribution and dispensing channels. And this may be done for different reasons. There could be an underlying behavioral health problem. It could be for pure profit motive, or it could be for some type of altruistic purpose. Misuse is use of a medication other than as directed or as indicated, whether willful or unintentional, and whether or not harm results. And then abuse is actually any use of an illegal drug or the intentional self-administration of a medication for a non-medical purpose, such as altering one's state of consciousness, leading to clinically significant impairment or distress. Just to reiterate, we're going to take questions at several points during the talk, so I'll be doing a little bit more and then be able to answer some questions. When doing urine drug testing, it's important to be clear about the rationale for use and what the response to the results will be. Explain to the patient that it's the expectation of regulatory agencies for monitoring of adherence and substance use. Focus on the risks and benefits of opioids and patient safety if you're using urine drug testing to monitor opioid use and other substance use. And understand that patients may have negative associations either from previous experience with urine drug testing in the jail and prison system or with jobs or in other situations. It's important to know the characteristics of the test and how to interpret the results, or who to consult to help you interpret the results. And it's important not to forego monitoring of function. That's one of the most important things to follow when treating people with chronic pain is their function and not just the results of a test. Regarding the things that it's important to know when you're interpreting results of urine drug testing, what tests are included. Not all drugs or medications are included in different urine tests. What the cutoffs are for negative results. What the half-lives are of medications or drugs. What the metabolic pathways of the medications are, because sometimes multiple opiates will show up when a patient's taking them because they're in the same metabolic pathway, and substances that can cause false positive urine drug test results. To help interpret results, it's important to collect information from the patient prior to obtaining a urine drug test. You can ask them these questions. When was your last dose of the prescribed opioid? Have you taken any other medications for pain in the past week? Have you used any other drugs or non-prescribed medications in the past week? And what should we expect to find on this drug test? This will help to open up a dialogue which is really important in trying to find out what's going on and then help understanding the results of the test. On to plan and management. Use a universal precautions approach. Most of us are pretty familiar with universal precautions as a term used in infectious diseases. It's difficult and sometimes impossible to determine a patient's risk of infectivity, say with HIV. Using lifestyle and past history and maybe non-adherence to determine risk can lead to stigmatization of the patient and to increase risk for the healthcare provider. To avoid this, an appropriate minimum level of precaution can be adopted and applied to all patients, and that's what universal precautions are. In pain management in homeless and other vulnerable populations, the rationale for doing this is that there are high rates of substance abuse and dependence. There's an increased risk of opioid misuse, abuse, and diversion. And there's difficulty detecting misuse, abuse, and diversion. The general approaches are to provide additional structure, for example, through treatment agreements and urine drug testing, and doing ongoing assessment, including ongoing assessment of function and ongoing assessment of aberrant behaviors or behaviors outside the treatment plan. The plan of care should include any needed testing or consultation to establish a diagnosis, determination of a treatment regimen to optimize functional status, and then it's important to make a structured, written, mutually agreed upon treatment plan. You can use patient-provider agreements and informed consent when opioids are prescribed. It's important to jointly identify indicators of functional improvement to determine if the plan's working. Make these tangible and measurable. As I said, develop them with the patient and consider using action plans for patients making progress toward meeting these goals. Some examples of function goals could be the ability to do chores in a residential treatment facility, having pain controlled well enough so that people can function in the roles that they need to function in treatment facilities. The ability to have a hobby, for example, taking care of pets or fish or something like that. Another functional goal could be the ability to get out and take a walk of a certain duration every day. Emphasize holistic treatment with multiple modalities. Things like self-care, pacing, and relaxation, physical activity. Medications may be considered both non-opioids and opioids, and then non-pharmacologic treatments. Cognitive behavioral therapy and acupuncture are two examples. In the plan of care, it's important to include a behavioral health plan. Identify and treat comorbid substance abuse and mental illness, and determine how behavioral health problems may be contributing to chronic pain and adapt the plan as needed. Make a plan for safe storage of medications. This is not only a concern in homeless populations, but many people don't have or don't think about having a safe place to store medications if they're prescribed, especially opioid medications. People can get a locked box, or if people are homeless, they can arrange for storage at a clinic or shelter. And it's important to adapt prescribing and dispensing as needed, depending on the plan for safe storage of medications. On to education and self-management. It's important to review the fundamentals of pain management initially and at every visit. And these are that it's a collaborative effort between the providers and the patient. It's important that patients have some level of acceptance of living with chronic pain, because getting rid of pain is rarely an option or a goal. The chief interventions are going to be things like pacing and relaxation and physical activity. Both behavioral approaches and medications are equally important. One isn't more important than the other. And a 30% reduction in pain constitutes success. We can't generally expect more than that based on studies that have been done. And then finally, it's important to identify and address any negative pain attitudes that patients have. Consider group visits. These can provide peer support, point of care collaboration of a multidisciplinary team. They can provide interactive group education. An example is Valley Homeless Healthcare in San Jose, California. They have a weekly group staffed by a multidisciplinary team for patients with chronic pain who they found were taking up a disproportionate amount of staff time. Most of the patients have co-occurring addiction and mental illness, and many of them have access to personality disorders. This is a weekly group, and it's resulted in higher clinician satisfaction, improved clinic efficiency and flow, and increased patient adherence and satisfaction. For the group visit curricula, you can consider a core curriculum with pharmacologic approaches, behavioral approaches, and complementary medicine. And you can develop more intensive group curricula for patients who have higher levels of need. For example, in Central City Concern, which is a program in Portland, Oregon, they have an occupational therapy curriculum for patients with a high centrality of pain as measured on the scale that I talked about earlier. And their curriculum includes topics such as body mechanics, communication skills, nutrition, relaxation, sleep, energy conservation and pacing, home safety and fall prevention, stress and time management, things like that. Then they have a group called Hot Sauce for patients with chronic pain and comorbid substance use. And that's a group that actually meets weekly for those patients. And some of the topics in that group are recovery basics, triggers and cravings, relationships, stretches, and stages of change. Other tools that you can use for education and self-management include self-management goal setting and motivational interviewing. On to treatment and management, and we're getting ready to stop for questions in just a minute. Select treatment based on the context and available resources. We talked about this at the very beginning. In on the streets or in a shelter clinic, if you're working with homeless patients, you may not be set up to provide many services, and it may be just a one-time visit. But you can actually help people with understanding the cause of the pain, making some simple changes that may help with the pain. For example, if you're in a shelter, you may be able to help the patient with getting bed rest or getting a board under their mattress for a firmer night of sleep. And then you can also let patients know, based on what you can see from their history and physical that day, what might be helpful in the future. For example, saying that when it's possible to get into primary care, it would make sense to see an orthopedic surgeon about this shoulder problem. So those would be the things that you can do in a setting where it's an urgent visit with few resources. If you're working in a full-service ambulatory care clinic, then you will probably have access to medications either on site or through prescriptions, and including opioids at some places. You may have access to physical and psychosocial interventions either on site or available via referral, and you may have access to specialty consultation. So what you can offer people will depend on where you are and what type of relationship you're going to be having with the patient, one time versus primary care or continuity care. It's really important to actually realize the possibilities and limitations of a setting. For example, and I mentioned this before, not all treatment settings are conducive to prescribing and monitoring opioid treatment. And so it's important to recognize that and provide it where it's safe, and you have the systems in place to do it, but not provide it where you can't do that. It's also important to advocate for the full spectrum of treatment if it's not available. Either if it's not available at your site, then trying to get the full spectrum of treatment available in your system is an important thing to do. Encourage early and ongoing non-pharmacologic treatment. The options for this are physical medicine, and that's a range of things, from physical and occupational therapy to having regular physical activity to exercise programs. Psychological therapies such as relaxation and pacing. Cognitive behavioral therapy, which is one of the more researched ways of improving chronic pain. Acupuncture. And it's important in the treatment plan to address psychosocial needs. Chronic pain plans will be less likely to work if things like finances, housing, relationships, and stress are not identified and managed. Non-opioid pharmacologic interventions can be offered, and these can be based on the etiology of the pain, the comorbid conditions, medications that are available, and other factors. The general classes are analgesics such as acetaminophen, nonsteroidal anti-inflammatory drugs, and then adjuvant treatments such as muscle relaxants and neuropathic pain medicines. I'm not going to be going into a long discussion about what medications to prescribe in what situations, but those are some of the possibilities. Opioids are another treatment option, and these are generally considered for people who have more severe pain and more impaired function and and worse quality of life, who are not adequately managed with other treatments or when other treatments are contraindicated. There are other guidelines that you can use to actually decide or help start and manage opioids. We reference 6 national guidelines in the Healthcare for the Homeless recommendations. The one I use most often is from the American Pain Society and the American Academy of Pain Medicine Opioid Guidelines Panel, and it's called Clinical Guidelines for the Use of Chronic Opioid Therapy in Chronic Non-Cancer Pain, which was published in 2009. And it's an evidence-based guideline that lays out what treatments they recommend based on the evidence or group consensus and how to go about managing opioids. If you're considering opioids, it's important to identify psychosocial factors that may complicate their use for homeless and other vulnerable populations. Some examples are emotional decision-making from mental illness leading to misuse. Some patients have trouble controlling the number of pills they take or adhering to a schedule, and that may make it more difficult to manage them on opioids, or may make it not safe to have them be on opioids. Opioids have a high street value, and in the setting of poverty, that can lead to diversion or higher risk of diversion. Opioids may precipitate or reactivate addiction in patients with a history of that. And some patients have poor self-management skills, and depending on your clinic setup and clinic staffing, it may be hard to manage those types of patients on opioids. And again, that's important to consider when starting patients on opioids. To monitor for, to promote the successful use of opioids by homeless and other vulnerable patients, it's important to have a written treatment plan, a patient-provider agreement and informed consent, and work with a multidisciplinary care team. To monitor for problems and complications, if patients are on opioids, it's important to monitor their functional status closely. How are they doing in terms of achieving their functional goals? Are they able to keep up with appointments and other day-to-day activities? Monitor for behaviors outside the treatment plan, and we'll talk more about that later. Investigate any functional decline or behavior outside the treatment plan, and when you do it, use a non-judgmental harm reduction or motivational interviewing approach. When problems or complications arise, consider a broad differential diagnosis. It could be that the patient's painful condition has worsened. For example, people with lumbar disc disease may have worsening disc problems and worsening of a radiculopathy. People may have an additional acute pain syndrome on top of their chronic pain syndrome. For example, a broken arm or shingles. Patients may have worsening of mental illness or substance abuse. They may have misuse of opioids. They may have pseudo-addiction, which I'll define for you. It's when patients display some behaviors that are consistent with addiction, such as requests for early refills or taking more medications than prescribed, but actually what's going on is that their pain is being undertreated. And this problem usually goes away if medication doses are increased. Diversion is another possibility when there's problems, and conditions of homelessness or poverty. An example of this is that homeless people or people living in poverty are more vulnerable to theft and of prescriptions or medications. They have more trouble keeping appointments because of more challenging transportation situations or being in jail. So you address problems or complications based on the etiology and severity of the issue. You may increase the opioid dose if pseudo-addiction is the issue. You may increase structure with more frequent opioid prescribing and dispensing and having a safe storage space if misuse is the issue. You may discontinue opioids if active substance abuse or diversion is going on. You may intensify mental health or substance use treatment, including residential treatment, if those problems are worsening. You may not know what's going on, and you may need additional information such as urine drug testing, pill counts, and prescription monitoring programs if they're available to you. And you may need further consultation if you don't know what's going on, either from peers or a team or a specialist, such as a pain specialist or an addiction medicine specialist. Other problems and complications are mental illness and cognitive impairment. Axis 2 personality disorders can complicate all aspects of treatment and negatively impact clinicians and other staff. Depression, anxiety, and PTSD often co-occur with chronic pain and really should be addressed simultaneously to have optimal outcomes. Cognitive impairment is a common and it may not be readily apparent, and it may interfere with adherence. For example, a patient with cognitive impairment may run out of medications early because he or she has trouble tracking when the medications are taken. On to follow-up. You determine the frequency based on patient stability, living situation, and risk of misuse. Patients with comorbid behavioral health issues on opioids may need weekly to monthly visits with random urine drug testing. In general, opioid prescriptions should be of shorter duration in homeless or vulnerable populations, 1 month or less in general. It's important to ensure a plan for opioid refills when the prescriber is unavailable if patients are on opioids. Follow-up. Review progress at each visit. All of these things need to be looked at. Where you are in the diagnostic workup, how the behavioral intervention is going, medication adherence and side effects, adherence to other treatments that may have been recommended, how folks are progressing on goals, both pain goals, function goals, and quality of life, whether or not people are responding to treatment, and whether or not patients have any behaviors outside the treatment plan. It's important to change goals and medications and other treatments as needed, depending on what you find when you complete a workup or how patients do. And it's important to review on a regular basis mental health and substance use and medication storage. At this point, we're going to take a moment to answer questions. And Sabrina, do I look at the question box, or how do we do this? And can everyone see this, or should I read it? Okay, great. Let me take a minute to read it. So the question really has to do about what you can offer for people in situations where there aren't opioids available and people have a lot of mental health issues. I would say that what are some of the non-pharmacologic recommendations? I'm not sure what's available in a correctional medicine situation, but I would say that some of the non-pharmacologic recommendations could be having people work on their coping and stress management skills, either as individually or in groups. I'm not sure how conducive correctional medicine situations are to groups. That may not be an option. Having people have some type of physical activity program, whether it's regular exercise or more simple physical activities. In terms of using long-term non-steroidal anti-inflammatories and muscle relaxers, I don't think there are good data to show that in the long term they're beneficial, and certainly for non-steroidal anti-inflammatory drugs you need to be very careful because they can have adverse effects on the kidneys and the stomach, to say, and as well as other systems, but they may be tried and may be able to be used PRN if people are monitored for side effects. In terms of other non-pharmacologic recommendations, again, physical or cognitive behavioral therapy has been shown to work, and if that is available, that would be something else to try. Acupuncture is there are less data to support that, but it does help in some painful conditions, and that would be another thing. Any other questions at this point in time? Okay. I'm going to move on to the next section, which is programmatic recommendations. When trying to design services, the important goals are to meet patient needs, promote consistency in practice among providers and among different sites, and make sure staff have the support they need. Consider different levels of services based on patient needs. Patients who have past histories of substance use, for example, may need a higher level of care and support than patients who don't. Try to have integrated care or one-stop shopping. This can help improve coordination, it can reduce triangulation, and it can improve the show rate. It's important to try to work in multidisciplinary teams. Patients generally have different needs that need to be met in managing chronic pain. And usually sites will have things like medical providers, nurses, social workers, psychologists. Some places have an addiction medicine specialist. Most primary care sites probably do not have that. And then clerical staff. Pharmacists and pain specialists and toxicologists can be very helpful in managing patients with chronic pain, especially patients on medications and especially patients on opiates. And if sometimes it's possible to actually arrange for pharmacists or pain specialists or toxicologists to come to a site one day a week or one day a month to help you manage, or you can refer to another site or at least have telephone contact with them to get input into how to manage patients. It's important to actually work with providers from other agencies such as mental health clinics, methadone treatment programs, residential and day treatment programs. Think about having group medical visits or pain clinics. These can provide education to patients. They can be used to do medication refills if patients are on opiates. They can be used to do other treatments such as acupuncture. They can be staffed in a multidisciplinary way so to try to meet different needs of the patient. And they may improve the ability to address the needs of challenging patients like we talked about at Valley Healthcare in San Jose. If you couple these with individual encounters with medical providers, the visits may be billable and may be more sustainable. Think about making non-pharmacologic treatment available. It's central to treatment of chronic pain. It's beneficial and it's less risky than opioids, but it often can be more difficult to access. You can have pain groups run by an occupational therapist or a behaviorist. You can think about having concurrent addiction and chronic pain treatment. Physical therapy is often an important important component of a treatment plan for chronic pain. And acupuncture and cognitive behavioral therapy are other important things to be able to offer, at least to some patients. Develop a relationship with the pharmacy. Consider having all your patients on opioids, which is a subset of the patients with chronic pain, get their prescriptions filled at this pharmacy, and then work with them to provide more frequent filling of prescriptions and dispensing of medications, and then use of Medisets or bubble packs for patients who need more structure or monitoring. Policies and procedures are also important in service delivery design. This can help systematize the practice and provide support to staff. It can protect the therapeutic relationship and improve the management of challenging patients. Include in those patient-provider agreements and informed consent for opioids. And you can also use practice guidelines to develop policies and procedures. In the policies and procedures, you can put in monitoring and tracking and review mechanisms. I'm going to stop again for questions because we're going to go on to a different section now. I see that there are no other questions. Does anyone want to type in a question?
Sometimes there's a little delay while they're...
So I'm going to give a chance for everyone to read this question. So the question First part of the question is how to motivate clients to attend outpatient support groups. And I think that can be a very difficult thing to do. I think trying to explain to people what the benefits might be, if it's possible for them to try it out once, or to get someone from the group to come talk with them or come talk with patients at the mental health center, that may be helpful. Those are things that might help motivate people. I think also really explaining to patients that chronic pain is not just does not affect people just physically, but also mentally and emotionally, and that it's important to have support in trying to manage it because it affects every part of people's lives. And having a support group is very helpful to get ideas from other people and to get help in trying to manage the problem. Now, the second part of the question, it's more a comment about a representative from a chronic pain organization establishing a support group. That's unfortunate to hear because I think it can be very helpful to experience something like that in order to be able to tell patients about it and recommend it. And one thing you might consider doing is seeing if the representative from the pain organization would be willing to come to your place and talk to patients or talk to staff about it and what the benefits are and what the group is all about. Any other questions? Okay. So now this is a picture probably most people will recognize, the Golden Gate Bridge. So it's close to where I live. And I'm going to talk about our experience in San Francisco with policies and procedures that we've developed in the area of chronic pain. As I mentioned, I work for the Department of Public Health in San Francisco, and we have 14 primary care clinics in the department. One of our policies is for monitoring and managing prescribing of opioids. And it's an example of a universal precautions approach and a structure for monitoring for and managing behavior outside the treatment plan. So the policy is called Aberrant Drug-Related Behavior in the Use of Controlled Substances in the Treatment of Chronic Non-Malignant Pain. And the purpose is to define uniform minimum standards across sites, across the 14 clinics, for monitoring, responding to, and documenting aberrant drug-related behavior. The term aberrant drug-related behavior is the same as behavior outside the treatment plan, and it's a general term that includes behaviors that result from many things, including abuse, diversion, misuse, and pseudo-addiction. And these overlap with behaviors resulting from the chaos and vulnerability of homelessness. I was talking earlier about the fact that sometimes that homeless people are more vulnerable to theft or assault, and so may actually have their prescriptions or medications stolen. And that's often considered aberrant drug-related behavior and maybe interpreted in a different way. So the first procedure in this policy is to monitor for aberrant behavior. And we actually have an aberrant behavior checklist in the policy. I've listed here some of the examples on that. It's not an exhaustive list. We probably have about 20 things listed. It's tough because it's the literature is not very good on what behaviors can be used to predict whether or not someone is misusing or abusing or diverting medications. And so in choosing our list, we tried to choose broadly, cast a broad net, and then have a consistent way of evaluating these behaviors. So the examples are a request earlier than expected, a report of lost or stolen prescriptions or medications, missing appointments with the provider, presenting to the clinic intoxicated or under the influence of drugs, abusive or threatening behavior towards staff, altering or stealing a prescription. More procedures that are in the policy. Get a urine drug test on initiation of therapy and then at least yearly on all patients. So the provider does not determine based on the person's risk or based on what they think is going on to get a urine drug test. All patients on opioids are to get a urine drug test initially and at least yearly. Pill counts can be substituted or added to that. Another procedure is to evaluate, including a differential diagnosis, and respond to each episode of aberrant behavior that's on the checklist. At that time, it's important to document a review of the treatment plan and the agreement with each episode with the patient. And then, for repeated aberrant behaviors, the policy calls for a mandatory documented peer review. In general, responses to aberrant behavior might be to monitor the patient more closely, dispense medications in smaller quantities, require substance use treatment, taper off controlled medicines, and talk with patients or colleagues if you're not sure what's going on. And again, it's important to respond to the behavior based on what you think is going on and how often the behaviors have happened and how severe they are. This policy can also help improve consistency, and it provides structure and support through the reviews for both providers and teams taking care of patients with chronic pain. Next, I'm going to talk about the Yellow Flag Committee. This is a committee we have at Tom Waddell Health Center, which is where I work. And it's one way that we do the mandatory documented peer review for repeated aberrant behaviors. We actually prefer the term yellow flag to red flag or aberrant behaviors, and we didn't invent that. We got it from another health center that uses that term. So the Yellow Flag Committee is multidisciplinary. It meets monthly to review hard cases of patients on opioids, and often, or invariably, these are patients who have had multiple aberrant behaviors. Any staff at the clinic can suggest a patient for review. Both the provider and the team working with the patient present the patient to the committee, and then the provider, the team, and the committee generate recommendations for care, and these recommendations are placed in the patient record. We've been doing this for about 6 to 9 months, and our results so far is that it provides an opportunity for providers to review the cases, which they often appreciate. It provides and promotes team dialogue around hard cases, and it provides support for both providers and staff by having the case be able to be discussed with the committee. We've found that the recommendations are often followed, and that this will hopefully promote more consistency in care. So for further information, you can check out the National Healthcare for the Homeless Council website, which is www.nhchc.org. That's where you can find the adapting practice recommendations that I was talking about tonight, and also find out more about the council and the clinicians network. You can email me. Here's my email address if you have want more information. And I think it's time for more questions now. Yes. Yes.
I have a question, Dr. Wismer.
Yeah, I think it depends on the patient. And I think it's important to figure out what you're looking for before you actually get the test. Sometimes it's to verify that the medication you're prescribing is in the urine, as you're talking about, that the patient is taking it. Sometimes it's actually to see if patients are taking unprescribed opioids. Sometimes people supplement their opioids with other opioids, and that's important to know for several reasons. Number one, it can be dangerous, and number two, it may mean that they're not taking their opioids as prescribed. Number three, it may mean that you're underprescribing the opioids. The other thing that you can look for in urine drug tests is whether or not people are using illegal substances, and it's important to know what your urine test actually has on it. For example, in our system, the basic urine drug screen does not include marijuana, but includes most of the other major classes of illegal drugs. And that's important to know, because if you have a person who has cocaine show up in their urine, it may indicate, again, this is the urine drugs test does not make this diagnosis, but it may indicate that the person has stimulant abuse problem and is using their opiate selling their opiate to buy cocaine. That's not invariably what it means, but it's important to know if your patients are using illegal drugs. The other thing, another unprescribed drug that people sometimes take are benzodiazepines, and those can show up on a urine drug test as well. And given those and opiates both have sedating effects, that can actually be a very dangerous situation. And so it's important to know if your patients are taking unprescribed benzodiazepines. So those are some of the things that you may look for in a urine drug test. There's a question from Janice Cooley. Boy, urine drug screens are very expensive, and so how do you use them judiciously? I think you may want to check and see if if you're only looking for certain things, just ordering that test may be cheaper, although you'd have to check with a lab. Sometimes combinations of tests or bundles of tests are less expensive, and use them judiciously. You may decide not to use them. Some programs don't use them at all, but I think that they can provide information that it may be hard to get otherwise. You may also make it a condition of people being on opioids that they actually have to pay for it, but that's a very tough situation to be in, and I'm not sure that would be the right way to go. So I don't have a good answer for that. I think trying to find ways of minimizing the cost of the test would be the best approach. Any other questions? Can you please show your email address? Here it comes.
Also, to the audience, we do have a link to the National Healthcare for the Homeless Council on our website in the share section. There's an entire section for the National Healthcare for the Homeless Council, and it's a good time for me to also add that
yeah,
in our share section.
There's actually another question. Do we have time to answer that?
Yes, we do.
Yeah. So the question from Diane Laura Evans is, do you have a sample of what you would place in a drug contract? So in the recommendations, we have an example of what we use for both an informed consent and a patient-provider agreement. And the informed consent is has things, I'm looking at it right now, and I won't read the whole thing, but just to let you know in general what's in it. The informed consent for opioids lets people know how opioids may impact their pain or may not impact their pain, and the risk of misuse by others, what the side effects might be, and the last thing is that people can get physical dependence on them, get tolerance, and become addicted to them. So the informed consent for opioids really sort of spells out the benefits, side effects, and risks of opiates. The patient-provider agreement that we use has a preface that says that we're doing this to make sure it's clear what the patient and provider can expect from each other. It talks about providers' responsibilities to make sure that the treatment plan is safe and complies with the law. And then in terms of patient responsibilities for the patient-provider agreement, it talks about patients agreeing to follow up with all parts of the treatment plan, including diagnostic workup and specialty consultation, etc., that the patients commit to taking the medications as prescribed and not letting others use them, following the rules of the clinic in terms of appointments and refills, guarding the medicines carefully, agreeing not to use illegal drugs. And those are the basic things in our patient-provider agreement. Any other questions? Yes.
I had one more. I'm not sure if I don't see any more that are
Yeah.
coming in. I noticed that when you talked about the clients that had the aberrant.
Yeah, I think that what we try to do is certainly if patients have behaviors that are disruptive or violent in the clinic, then we, depending on the severity of the behavior, we have a safety committee that evaluates the behavior, and we will do a behavioral agreement with a patient about the expectations of their behavior at the clinic. If it's a very problematic, violent behavior, they may be permanently denied service at the clinic, and we have a system for, since we're the safety net system in San Francisco, for figuring out a safe place for them to go somewhere else. With regards to opioids and the patient-provider agreement, separate, if there's not disruptive or violent behavior and patients are not following the treatment plan, given we've set up, we have the patient-provider agreements, we may decide that opioids aren't working, or the patient's not following the treatment plan and it doesn't make sense to continue with opioids but not the other things, and we may discontinue the opioids. We usually do not dismiss the patient from our practice. We usually keep them in our practice and continue to work with them using motivational interviewing and try to engage them in care. But just because they stay in care doesn't mean that we're going to continue to prescribe opioids or other treatments that we don't think are beneficial without follow-up in other areas. I think that it probably varies from state to state, but there are laws about declining to see a patient anymore. And I think that if you get to a point where you're not able to work with a patient anymore, it is, there may be someone else at the clinic who can actually do that, or you can provide patients with options, other places in the community where they can go to get care. I don't know if any other questions, or? Okay. Thank you, everyone. I don't know. Any other questions? Or?
I think that's it. Thank you very, very much for such an engaging presentation tonight. Thank you to our audience as well for your questions and comments. You really added to our production. I'd also be remiss if I did not say thanks to our IT extraordinaires, John and Quallen. Again, this Primary Care for All webinar series is made possible through a partnership between the National Center for Primary Care, the Association of Clinicians for the Underserved, the National Healthcare for the Homeless Council, Clinical Directors Network, and Migrant Clinicians Network. This partnership allows us here at Primary Care for All to serve as a resource for National Health Service Corps members. Direct support for this webinar series was made possible with direct support from the U.S. Department of Health and Human Services, HRSA, and the Bureau of Clinician Recruitment and Services. Please note the upcoming events at the center of your screen, and also remember that the resources have been posted to our website. A tab for a CE quiz should be popping up in your web browser as we speak. Please complete it